Hello everyone, Dr. Suresh here, Professor of Biochemistry, and in this video we will be talking about the disorders related to tyrosine metabolism. So in all the other way, it is related to the phenylalanine metabolism as well, because tyrosine is non-essential amino acid, whereas phenylalanine is an essential amino acid. So when you take phenylalanine through diet, phenylalanine will be converting into tyrosine in the cells, right? So this way tyrosine is synthesizing from phenylalanine, that's why it is non-essential, whereas phenylalanine is an essential one. So that's why the disorders related to more or similarly you can correlate with phenylalanine as well as tyrosine. But the main prominent disorder of phenylalanine metabolism, that is phenylketonuria, because of the first step of conversion of phenylalanine to tyrosine, the inability. So there are certain disorders which related to tyrosine, especially after the processing. So if you have an overview, if you look into the overview of phenylalanine metabolism, tyrosine. So first thing is phenylalanine, which will be converting into tyrosine by the enzyme phenylalanine hydroxylase. So if this enzyme is deficient, you will be getting phenylketonuria, right? This is again one of the genetic disorder related to aromatic amino acids. So now once tyrosine, if there is no problem in conversion into tyrosine, the next steps which requires the enzymes related to tyrosine metabolism. So here, if there is a deficiency of tyrosine transaminase, which is a PLP dependent enzyme, that means pyridoxal phosphate B complex, B6 coenzyme form. Okay, so because of the deficiency of tyrosine transaminase, you will be getting tyrosinemia type 2, that is Richner-Handrud syndrome. Okay, and again next is para-hydroxy-phenyl pyruvate hydroxylase. If this enzyme is deficient, it is a copper based enzyme, copper dependent enzyme, so you will be getting neonatal tyrosinemia, that is type 3 tyrosinemia. And if homogeneous acid not converting into malleol ester state, high levels of homogeneous acid will be there, that is leads to a condition alkaptonuria. And if further malleol ester state conversion into fumarate ester state and fumarate ester state to ester state and fumarate, because of deficiency of the enzyme fumarate ester state hydrolase deficiency, you will be getting hepatorenal tyrosinemia, otherwise known as tyrosinemia type 1. Okay, so here we will be discussing mainly about tyrosinemia type 1, tyrosinemia type 2 and tyrosinemia type 3, because phenylketonuria and alkaptonuria, they are again further separate topics which has to be studied elaborately, and we have already done in our previous videos. So first we will discuss tyrosinemia type 1. So the other names for tyrosinemia type 1 is tyrosinosis or hepatorenal tyrosinemia. It is a rare condition but serious condition, right? So here the enzyme deficiency is fumarate ester state hydrolase. So because of the deficiency of this enzyme, fumarate ester state cannot be converted into ester state and fumarate, which are, because we have already learned that amino acids are glucogenic, ketogenic, both glucogenic and ketogenic. When they undergo degradation, they supposed to, their carbon skeleton supposed to enter into gluconeogenesis, otherwise ketogenesis. So as being a complex structure, tyrosine, part of its structure will go into gluconeogenic pathway, part of it will be going into ketogenic pathway. So as because of this fumarate ester state hydrolase deficiency, it cannot be entering into ketogenesis or gluconeogenesis. So now there will be high levels of fumarate ester state levels, and because of that malleol ester state levels also there, as there is no process, there is no inhibition of feedback inhibition, so tyrosine levels also elevated, so which leads the symptoms like liver failure, renal tubular dysfunction, polyneuropathy,
turn off the charger,
vitamin D resistant, succinyl ester state, there are other malleol ester state will be converted into succinyl acetone, and fumarate ester state will be converted into succinyl ester state. So here tyrosinemia type 1, so as increased levels of tyrosine transaminase deficiency, para-hydroxyphenyl pyruvate undergo dehydrogenation to form para-hydroxyphenyl lactate, the byproducts, and acetyl-CoA comes into the action, converts tyrosine into N-acetyl tyrosine, and tyrosine decarboxylase come into the action to form tyramine and para-hydroxyphenyl acetate. So alternative catabolic pathway for tyrosine in tyrosinemia. So these are, otherwise it will be entering into gluconeogenic, ketogenic. So as there is deficiency of that particular enzyme fumarate ester state hydroxylase, So the alternative metabolic pathways, metabolites of tyrosine is para-hydroxyphenyl lactate, N-acetyl tyrosine, and para-hydroxyphenyl acetate. So what are the other consequences? Serum methionine levels, which are secondary to liver failure, urinary excretion of methionine, hypertrophy of Langerhans leads to pancreatic failure, and which is stimulated by methionine. Succinyl acetone and succinyl acetoacetate are the one which will be doing all the work in stimulation of hypertrophy of islets of Langerhans. So here the aminolevulinic acid, two molecules which are required, like what to say, PBG synthase aldehydrate enzyme, they block this in making of parphylinogen. So excretion of delta aminolevulinic acid in urine similar to acute hepatic porphyria. So don't get misconfused with the tyrosinemia type 1 and acute hepatic porphyria. So acute condition, survival is not possible beyond a year. In chronic condition, death by age of 10 years. So here in tyrosinemia type 1, cabbage like odor, phenylketonuria, it is mousy odor, okay, and vomiting, diarrhea, failure to thrive, similar to acute conditions but milder. So tyrosinemia type 1, what are the diagnosis? High levels of tyrosine in blood you can make out, with that, and molecular genetic testing of FAH gene mutations, and what is that? Fumarate acetoacetate hydroxylase gene mutations. Newborn screening programs like succinyl acetone, tandem mass spectroscopy identification, carrier testing, and prenatal diagnosis by DNA analysis. Prenatal diagnosis, that means detection of succinyl acetone in amniotic fluid. It is also possible to identify type 1 tyrosinemia. So treatment, diploin, phenylalanine and tyrosine. Nitisinone is a drug which is like a dioxinase inhibitor which inhibits the formation of para-hydroxyphenylpyruvate formation. And tyrosinemia type 2, if you see, this is Richner-Hanhart syndrome. It's very rare. Clinical features are mental retardation, eye lesions, corneal erosions like in photophobia, skin lesions of the soles and palms like palmoplantar keratosis is a more prominent feature. Diagnosis, elevated levels of tyrosine in plasma and urine, increased excretion of tyrosine metabolites. Treatment, restriction of phenylalanine and tyrosine in the diet. Vitamin C also plays, to minimizing the symptoms of this tyrosinemia type 2. Because B6 supplementation also, because tyrosine transaminase enzyme is a PLP dependent enzyme. And type 3 is a neonatal type, neonatal tyrosinemia. So high serum tyrosine levels in premature infants. Immature liver has limited ability to synthesize the enzyme. So high tyrosine levels cannot be processed. As the liver matures, the accumulated tyrosine is metabolized. Serum level decreases within 4 to 8 weeks of age. It is benign condition and responds well to ascorbic acid. So if you compare all the disorders of tyrosinemias like type 1, type 2, type 3. So tyrosinosis or hepatorenal tyrosinemia is type 1. Richner-Hanhart syndrome is a type 2 tyrosinemia. Neonatal tyrosinemia is a type 3. It is a benign condition. So serious one is type 1 and rare condition is type 2. Benign condition is type 3. Because in neonates, liver is immature, it cannot synthesize the proteins as fast. So tyrosine cannot be metabolized. As with the progression of the time, with the age, tyrosine will be metabolized. An enzyme defect, if you see in type 1 tyrosinemia, fumarate acetoacetate hydroxylase, but in tyrosinemia type 2, it is tyrosine transaminase, and in tyrosinemia type 3, para-hydroxyphenylpyruvate hydroxylase is a deficiency. And biochemical basis, accumulation and excretion of tyrosine and its metabolites in the urine. And in type 2, accumulation and excretion of tyrosine and metabolites in the same urine. Increase in tyrosine but returns to normal within 4 to 8 weeks of age. Clinical conditions, if you see, diarrhea, vomiting, cabbage-like odor, skin and urine, succinyl because of the presence of succinyl succinyl acetone. First year of life, death is possible. Liver failure, kidney dysfunction, polyneuropathy, vitamin D resistant rickets. So if you see the type 2, mental retardation, eye lesions, corneal erosions, photophobia is a prominent feature of type 2 tyrosinemia. Skin lesions of the soles and palms, palmoplantar keratosis you can make out in tyrosinemia 2. And diagnosis, detection of tyrosine metabolites like succinyl acetone in urine, detection on tyrosine metabolites in urine, same in type 2. but that feasibility is not there with type 3, that is neonatal tyrosinemia. In treatment, diet low in phenylalanine tyrosine improve the situation. Same type 2 also, diet low in phenylalanine tyrosine along with vitamin C, and neonatal tyrosinemia, vitamin C administration may improve the situation. So that's all about different types of tyrosinemias and their characteristic features concern enzyme defects. So thanks for watching. Thank you.